Hello, dear friends. Today's talk is about arrhythmias. Almost everyone faces heart rhythm disturbances. Only some people do not feel them, and some notice them very much. In general, any irregular heartbeat is called an arrhythmia. They can be too slow contractions, too fast contractions, or individual irregular heartbeats. How can we notice arrhythmias? We may feel that the heart starts to beat in a specific way, gets out of rhythm, or the opposite, some faltering and pauses. Some people, in addition to these unpleasant sensations in the chest, may experience dizziness, confusion, sweating, anxiety, and shortness of breath. Sometimes, it can also provoke pain in the heart area. In some cases, arrhythmias can be virtually harmless, and in other cases, they can threaten the life of the person and those around him if, for example, the person is driving a car or bus or is a pilot of an airplane. To understand why arrhythmias develop, we must first understand how the heart's conducting system works wholly. Two types of heart cells work to achieve normal cardiac contraction. The first is the muscle cells that contract. They make up the majority of the heart. They shorten to reduce the volume of the heart chambers and push blood out of them. The second type is the conducting cells. These are specialized heart cells that generate and conduct electrical impulses that cause the heart muscle to contract. The sinoatrial node usually initiates the heart rhythm simply because it generates impulses faster and more forceful than other areas with impulse-generating potential and, in a calm state, causes about 70 discharges per minute. This stimulus travels to the walls of the atria to stimulate their contraction. It then propagates toward the ventricles. Before reaching the ventricles, the signal passes through the atrioventricular node, the atrioventricular bundle called the bundle of His and its branches, left and right pedicle, which ends with Purkinje fibers. The impulse distribution through the cardiac conducting system takes time, and by the time the ventricles contract, the atria have already relaxed. So we know that the generation of impulses in the heart occurs in the sinoatrial node, located in the right atrium. The cells of the sinoatrial node have automatism, meaning that they can generate impulses and these impulses. Then they propagate sequentially to the atria, atrioventricular node, interventricular septum, and the left-right ventricle, causing a coordinated contraction of the heart muscle. In addition to the autonomous generation of impulses, the sympathetic and parasympathetic nervous system acts on the sinus node. The sympathetic nervous system activates the sinoatrial node. It means it raises the heart rate, while the parasympathetic nervous system, conversely, inhibits it. In addition, some hormones can affect the development of high HR. These are adrenaline, noradrenaline, and thyroid hormone. For example, when the thyroid gland is insufficient, the heart rate is, on the contrary, shortened. It also occurs in endurance sports when the tone of the parasympathetic nervous system begins to prevail. Therefore, athletes often develop bradycardia. What are bradycardia and tachycardia? A contraction of 60 to 100 beats per minute is considered normal for a person. If the contraction is less than 60 beats per minute, it is called bradycardia. If the contraction is higher than 100 beats per minute, it is tachycardia. There is tachyarrhythmia with an increased heart rate and bradyarrhythmia, in which the heart rhythm breaks down and the heart contractions become less than 60 beats per minute. Bradyarrhythmia is a variety of blockades. The blockade is a violation of the conduction of the impulse through the conductive system of the heart. With high degrees of blockage, the heart ceases to work adequately in response to physical activity, and a person may develop a pulse of 20 to 30 beats per minute. Naturally, with such a pulse, one cannot perform even the usual simple work on self-care or household chores. Therefore, these people, at the slightest physical load, begin to experience various symptoms of circulatory failure. Tachyarrhythmias have the opposite effect. Too frequent heart contractions cause the heart to contract insufficiently. Imagine a pump that we pump in full, for example, with a specific frequency, and suddenly we decide to pump with a small amplitude, for example 1 millimeter, but very often. Naturally, the performance of such a pump drops. The same situation occurs in tachyarrhythmias, when the heart begins to contract too quickly. It does not have time to push out all the blood and shock volume, Therefore, the amount of blood that is pumped out in one cardiac cycle falls, resulting in a drop in blood pressure, and not enough blood flows to vital organs, particularly the brain. From this, dizziness develops, loss of consciousness, and other adverse symptoms can occur. The most common mechanism of arrhythmias is reentry, which is responsible for most of both supraventricular and ventricular tachycardias. In this case, excitation waves enter the heart circularly, thus including the so-called closed circle. This closed circle of electrical excitation stimulates the heart to contract at a high frequency. The second mechanism is the appearance of activity of so-called ectopic centers. As you already know, impulses are generated in the conduction system of the heart. Once the impulse generation starts, for example, in some other part of the heart, say in the right or left ventricle, and interrupts already normal impulses that come from the conduction system of the heart, it causes the appearance of ectopic activity. As a rule, those arrhythmias that originate from the atria are much less dangerous than those arrhythmias from the ventricles, which result either from ectopic activity or from the circulation of an excitation wave that occurs within the ventricles. The severity of the arrhythmias still depends on what consequences they can cause. Some arrhythmias may go away on their own. Some may cause the heart to contract chaotically. At first, polytopic ventricular tachycardia may develop, that is, from multiple locations, and this condition can lead to ventricular fibrillation. Fibrillation is a chaotic and disorderly contraction of the ventricles when there is no need to talk about any pumping function. The cause of arrhythmias most often is either congenital anomalies of the conduction system of the heart, valve malfunction, cardiomyopathies, consequences of myocardial infarctions, or intoxication with some drugs. Sometimes, acquired rhythm disorders can occur due to sports. Some athletes who train for endurance may develop overstretching of the right atrium, as a result of which it becomes unable to conduct impulses properly and starts to produce discharges on its own in different places, which leads to chaotic atrial contraction. They may develop atrial fibrillation or atrial flutter. An electrolyte imbalance, such as potassium or magnesium deficiency, can also cause arrhythmias. As a rule, those arrhythmias that are associated with cardiac pathology, associated with a disruption of the heart's conduction system, which provides coordinated and regular myocardial contractions, can cause life-threatening complications. Inorganic or functional arrhythmias that are not associated with cardiac pathology, as a rule, do not cause health and life-threatening complications. For the diagnosis of arrhythmias, an electrocardiogram is used. On the ECG film, we can see where the rhythm disturbance comes from and whether it is dangerous. It is also necessary to provide the doctor with information about the conditions under which the arrhythmia occurs, for example, at rest or on exertion, whether it develops suddenly or gradually, and in general, how it runs, whether it is constant or in attacks. There's a catch. An arrhythmia attack doesn't always happen when you get to the doctor's office, and so taking a cardiogram may show a perfectly normal pattern. To catch that moment of arrhythmia, they came up with a study called a Holter monitor. It's a recording for 24 and sometimes 48 hours. Extended monitoring is used to catch this episode of arrhythmia. As a rule, a small box is worn on the belt and about 5 electrodes are glued to the chest. 24 hours a person wears this device. If necessary, when there is some unclear sensation in the chest, a button is pressed. That is, a signal is given that something is happening, so that it can be compared with the electrocardiogram. At this time, the person is offered to engage in their usual activities in order to stimulate all possible and impossible conditions under which an arrhythmia may occur. When the arrhythmia is detected in this way, it becomes much clearer how it occurs, where it comes from, under what conditions it occurs, and in general by the number of extrasystoles, the number of episodes. In addition to Holter monitoring, of course, echocardiography is also used. As I've already said, most arrhythmias occur against the background of organic changes in the heart. Echocardiography is used to see whether there is no cardiomyopathy, whether the valves are working well, and whether there are any zones of hypokinesia that can occur during myocardial infarction. Sometimes electrophysiologic study is also used. It's recording the potential from the conductive system of the heart. It's a complex study, usually performed in large cardiology centers. Fortunately, most arrhythmias are safe. It is possible to assess their danger for yourself approximately in the following way. If arrhythmias occur at rest and disappear with physical activity, then these are some functional changes, and it is unlikely that they are dangerous. But there are always exceptions to all the rules, so only one of these signs should not be focused on. Sometimes, severe rhythm disturbances can be asymptomatic and then cause some sudden loss of consciousness. The second criterion is symptomatology. The more pronounced the symptoms, for example, confusion, dizziness, heart pain, and so on, the more severe the prognosis, as a rule, for arrhythmias. Again, though, there are exceptions. The treatment of arrhythmias is a complex process, and it is difficult, almost impossible for the patient to cope. You can help yourself in this way. In an attack of tachycardia, you can try to apply the Valsalva maneuver. It consists of taking in air, holding your breath, and strongly tense the abdominal muscles. Thus, there will be stimulation of the vagus nerve, and it will slow down the heartbeat. There are conflicting opinions about the effectiveness of this method. Many doctors use it, but the Cochrane database is a compilation of evidence-based research in medicine. The Cochrane database does not give us any definite answers. It mentions that the Valsalva maneuver needs to be studied. In my practice, I can say that in my case and from my experience, it is pretty efficient. Apart from the Valsalva maneuver, there is nothing else to be applied. And that is only in the case of so-called supraventricular tachycardias, namely those that develop above the ventricles. For everything else, the treatment depends on arrhythmologists, some of the most intelligent doctors in the medical world. They decipher what kind of arrhythmia and can prescribe specific antiarrhythmic drugs if it is tachycardia, or they can put a heart rhythm stimulator if a blockage develops, or they can remove some additional conductive pathways in the heart with the help of radio wave ablation. Of course, this issue is already solved in specialized medical centers. If you have symptoms of an arrhythmia, you should not delay visiting your doctor. It is necessary to understand whether the arrhythmia is dangerous and what lies at the root of it. It is possible to calm down or to take further actions to preserve your health only in this way. Thank you very much for watching my video. Stay healthy, and may you not be bothered by arrhythmias. See you later. Always for you, Dr. PopMed.